All right, so we're recording. Just remember that. So no swearing or anything. All right, I just had to say that. Okay, so remember there's free CME, so just make sure you fill out that thing when you get it, and you'll get your free credit.
Yep, and please let us know if there's other people in your room to make sure they get the credit, and videos are always cool.
Yeah, we'd love it. I'm sure Murray would much rather talk to your face than a black box, so feel free to turn it on. All right, next slide. So upcoming, we have perioperative management on Tuesday.
Not for a couple of weeks.
Yes.
So anyway, you can read those. Next week, we are not having a Wednesday echo. We're going to take a holiday off. And then you can kind of see what's coming up. Pretty excited about the very random variety we have coming up. So
yeah. All right, next slide. So remember, if you need any help, please feel free to reach out to Aaron or us. Our numbers are there. Don't be afraid to call if you have a question or an issue with a patient that you want to learn a little bit more about or tell us about.
All right, and then we have our online site. Of course, that's up. We've been talking about. So if you want to see what other echoes that we are associated with, you can go there. You can register from there. You can access the case presentation from there. We are going to, I don't know what's all up there yet as far as old recordings, but that is where you will find it. And then we will start to continue to update all the the clinical forms and policies and such will all be there. So check that out. That's just how to find the case form. Yeah. Click on the echo you want to be a part of, and you will find it.
Perfect.
That's a complicated slide.
I think today was...
Yesterday was the methadone clinics pre-COVID. So what did a methadone clinic, what are the logistics? Next week will be what happened to the methadone clinics, the OTPs, during COVID with all of the restrictions and the social distancing. And then the week after that is about the transitioning of methadone to Suboxone. Should you do it? How do you do it? All the things with Charlie.
They're all with Charlie. So they're pretty fun. All right. And now we can move to Dr. McAllister's nice, fun talk. So
do you want to introduce him?
Well, I can let Murray introduce himself. He can tell everybody where he's at, what he's doing for fun. Go ahead, Murray. You could go ahead and just take over. Just
remember that we would all love to refer every one of our patients of all types to Murray. It's just not possible because we get priority. No?
That's right. So we're not telling you where he is.
Right. No. All right, Murray. We'll let you take over.
Well, thank you. I appreciate that. I'll do a quick introduction, but then I need to remind myself, how do I start showing my PowerPoint?
Click the share screen button at the bottom.
Or you can.
Oh, yeah. Okay, here. Sorry.
Okay.
I got it. Okay. And then share. Sorry.
There you go.
Okay. And everybody can see it?
Yep.
Yes.
And then if you want it to be in PowerPoint view, you can go to the slideshow, start from the beginning.
Okay. Well, I'll do that in a second. I can do a little quick introduction. Hi, everyone. I'm Murray McAllister. I'm a pain psychologist by training, but for most of my career, I've run and designed pain management systems of care, and most recently has been with Courage Kenny and Alina Health. And then in addition to that, I've always had a small practice, a consulting practice for helping health systems or clinics design pain care delivery. Recently, though, I've had kind of a change in life. I did leave my leadership roles at Alina, and I've gone back to part-time patient care, and then I'm going to be doing the consulting part-time as well. I'm particularly interested in disrupting pain care, especially the last 3 decades of pain management, recognizing that with the various problems that have been associated with pain management over the last 2 to 3 decades, that we really need to look at how do we redesign pain management and make it more effective and safer. That's what always brought me to the Echoes, and I always appreciate being able to talk here. I really appreciate the culture that this has. I mean, and I think Kurt and Heather and Aaron and Katie and your whole team has really, I think, done a great job in creating a culture of respect and collegiality and challenging, challenging the status quo. So that's awesome, which is kind of what I want to do today as well. So let's see, slideshow. Was it 5 weeks ago or 6 weeks ago? I did a presentation here on cognitive behavioral therapy for pain management, and kind of at the sort of the higher level of what is CBT for pain management, and how it's effective, and how to train, sort of making the contention, of that all providers in a pain management service, whether they're psychologists or physicians, nurse practitioners, PAs, PTs, OTs, whatever the type of providers, should have some basic understanding, and not just understanding, but training in how to deliver and approach patients from a CBT perspective. And so that then led to the question of, like, I think it was Heather who asked, could you come back and do some of that training, and could you come back and do a presentation on how you might train people to do this? So that's kind of what I'm trying to do today, in terms of like the fundamentals of cognitive behavioral therapy for pain management, for the non-psychology provider that's working in the pain service. So here's my disclosures. Like I said, I do still work for Courage County part-time. And then I also have the Institute for Chronic Pain, which is a publishing, internet publisher of all things related to pain, and we do consulting out of that as well. I am going to be using some copyrighted material from the ICP. I think I've kind of just gone over the objectives, sort of our agenda today. Psychologists for over 100 years have been studying how to help people make changes in their life. And there's kind of two broad categories of what we call non-specific factors and specific factors of therapeutic change or intended change. And we're going to talk about that distinction, and then start to talk about more specific, what those specific factors of change are, which is, from a CBT perspective, we're going to talk about some just general CBT fundamentals of whether you apply this to whatever presenting condition, whether it's pain or depression or obesity, heart disease, diabetes. What are the basic fundamentals of CBT? And then move that even more specific to CBT for pain management. For one reason is because, we always have to start with the fundamentals, in doing any kind of training, I think. And then second, we have to train our patients. We have to get our patients to a place where they are ready for CBT of pain management, for pain management. So I think there's a lot of prep that we do with our patients in order to get them to the point of where I was talking about last time, 5 or 6 weeks ago. So I think that speaks to Heather's question. I don't know, Heather, if you remember that question, but you're like, well, how do you do that? I mean, it sounds good when you say it, Murray, but like, how do we do that? And what I failed to mention last time is, like, to get a patient to that point requires a lot of preparation. And that's what we're really going to focus on. 80% of today is going to be focused on that preparation to get them to what I talked about last time. So in the interest of disruption, here's some challenges for you. I would put to you that if you are providing pain management services, your job is not to alleviate pain, and nor is it to treat pain, and nor is it even to manage your patient's pain. This sentiment that it is our job as healthcare providers to treat and alleviate pain for our patients, I think has led to the last 20 to 30 years, of exponential growth rates in scans, interventional procedures, spine surgeries, core strengthening, physical therapy focused on core strengthening, and of course the use of opioids. This is what we're going to later come to see. This is the acute care model, right? We're going after the condition itself. We are the experts, and we are going to treat that condition and make them better so that they can resume their normal life. And I would say that sentiment, that approach, has created a heck of a lot of pain care. Certainly has made certain providers a heck of a lot of money. But we also know that there's this corresponding exponential growth rates in Social Security disability claims for pain. We have exponential growth rates in opioid use disorder. And interestingly enough, even from an epidemiological perspective, people are starting to report more pain over the last few decades. Just in general, people in general are reporting that they are having more pain than they did in the 90s and in the 70s. And isn't that interesting? So this is what happens when you leave your leadership roles in a large health system. I get to start talking like this, and I don't have to mind my P's and Q's as much as I used to. I think it's time to get real. How good are we at alleviating pain? Really? When we look at these disability claims for pain, the OUD rates, the increasing pain levels in the general population, not to mention the amount of money the American healthcare system is spending on pain management, can we really say that we are helping? And might we even say that, are we potentially harming our patients and society? When do we get to start talking about iatrogenic harms that we are producing? And are we showing effectiveness with this acute care model? I've sat in a lot of committees where, this is verboten stuff. But there's analogies. There's other areas of healthcare. If we were managing a surgery service and we're tracking the amount of times that, sponges get left in bodies or wrong body parts have surgery on, we're all over that. And we expect our surgical groups to be all over that. Society expects us to be all over that and learn from those mistakes and develop systems of care that prevent those sorts of things. And we do that. But do we really do that in pain management? I don't think we do. And I think we need to start talking about this and creating a culture without blame, without shame, but to say, what, this is really happening, and we really do need to redesign how we manage pain, making it more effective and safer. So what is your job as a pain management provider? I would say to you, you are a behavior change expert. That's what we are here to do. Now you're going to say, oh, well, you're just a psychologist, and of course you're going to say that, because that's what you're an expert in. But bear with me. I think, a strong case can be made that if we're really going to design a more effective and safer pain management system of care, we have to really focus on what works and what we know works. What are the empirically supported therapies of care? And lo and behold, they're all about behavior change. They're not about providers who are experts who are doing things to their patients in order to make their patients healthier. It's really those procedures, those approaches are not empirically supported. What is empirically supported is when we switch that around and say, we're going to coach these patients on how to get better themselves. So what do? We educate, we motivate, and coach. And health behavior changes, which when done over time, have a physiological effect on their nervous systems, neuroplastically changing them so that they have less pain and more ability to cope. And in many ways, we can extinguish pain that way. Now, notice my little footnotes, 1 and 2. Like I just said earlier, the empirically supported treatments, and we went over those last time. I didn't have a slide to remind us, but the pain rehabilitation programs, it's CBT, it's physical therapy, it's mindfulness training, it's meditation, Tai Chi, yoga, certain non-narcotic medications that are targeting the nervous system. All of these therapies, the common denominator is that they're targeting the nervous system and trying to retrain it to be less reactive, so it produces less pain in response to stimuli. And those are the most empirically supported therapies, of which CBT is one, particularly for the most common conditions like low back pain, neck pain, headaches, fibromyalgia. Now, I would also say all of this pertains to and relates, is applicable to, I should say, rheumatoid arthritis, sickle cell, cancer, post-surgical pain. But those are, there is, but those are a little different. We're not going to go into a whole lot about that. A good state-of-the-art pain management service in a health system, should have CBT in their, post-surgical departments and et cetera. The very first empirically supported treatment that the American Psychological Association came about to say after reviewing all the evidence was pain rehabilitation programs for rheumatoid arthritis. That was the very first empirically deemed empirically supported treatment. But we're not going to, those are a little different. There's some subtle differences. We don't have time to go into all that. So what are these non-specific, I need to keep it aware of the time. What are these non-specific and specific factors? I mean, essentially, when it comes to healthcare, as opposed to doing CBT training for an athlete or whatever, or changing a business organization, et cetera, if we're really talking about, healthcare, the non-specific factors is really the therapeutic relationship. And then the specific factors is, say, for example, cognitive behavioral therapy, or if it's, there's different types of therapies that can be done for different conditions. And those are the more specific strategies, all of which have these non-specific factors as well, essentially the therapeutic relationship. And we need to talk about the therapeutic relationship because, it's probably the most important thing here. I know this is a talk on CBT for pain management, but we, if we're honest with ourselves, 80% of behavior change is really ultimately related to the therapeutic relationship, regardless of the specific ways that you intervene. And so we do need to spend some time. In fact, this could be a half-day seminar on the therapeutic relationship. But just to kind of get our feet wet, and we'll move on. Just do a quick thought experiment. Who are the 1 or 2 most important people in your life? Who's the person who got you into medicine? Who started to open that door and allow you to start thinking that it was possible to become a nurse practitioner or a physical therapist, or, or who is that person, maybe it was that high school English teacher who you sort of like helped you see how you could start to actually write and appreciate literature, or got you into, you name it. It's not that these people were like world-renowned experts in their field, right? They weren't, Einstein, and all of a sudden you then became a physicist. They could have been your grandma, it could have been the high school English teacher. It could have been that biology professor who sort of took you under the wing and started to like open up a world of how, of how fascinating biology could be. And from there you went into medicine. It was what differentiates those people from all your other authorities in your life were really, was the quality of the relationship that you had with them and their ability to connect with you and their connectability for you able to connect with them. My kids are getting a little older now. My last daughter is going to be a senior in college, but a number of years ago, we were doing all these college tours, right? And they got accepted to X, Y, and Z college, and we would go tour them. And the time we learned, what was the single biggest predictor of a kid picking that college? It wasn't the reputation or the professors or the blah, blah, blah. It was how well they connected with that college level tour guide who was touring you through the campus. If they connected with that kid, if they saw themselves in that kid, that's the college they wanted to go to more often than not. If they couldn't relate to that kid, it was more often than not, they don't pick that college. We are inherently relational animals. We are mammals, and particularly higher order primates, and we connect. We are like dogs. We run in a pack, right? And a solitary wolf doesn't last very long. It goes a little, it gets unhealthy. We need to be in relationship. And what allows us to adapt and adopt most readily is our drive to attach. And attachment's about, as I've talked about in other Echo Project, other presentations, it's about opioids and oxytocin and dopamine. That's the underlying attachment mechanisms through our nervous system that we attach with other, hopefully healthier objects. And when we attach to healthier objects, we start to adapt and adopt to them and start taking on those characteristics. And when we, and we start to lessen those more unhealthy, those less healthy attachments. So how do we do this? I mean, again, remember, the majority of therapeutic behavior change is not so much the exact type of therapies you're delivering, it's how well you're connected with that patient. And so how do we do this? How do we do this intentionally? Well, when you go through that exam door, when you log onto your virtual visit, you really have to make an effort to put everything else aside and be present and attend to them. About 5-6 years ago, my primary care physician, or actually he was an internist, decided he had been moonlighting as a hospitalist, and he decided he wanted to become a full-time hospitalist. And so I was in the market of having to find a new primary care provider. I was just astounded by how little effort people were, putting into just being present. They'd introduce themselves and they'd just like walk over to the desk and sit down and stare at their computer. And every once in a while they might look at me and they're like, one person did acknowledge that I'm going to be looking more at my computer than you, but most of them didn't. And I was just like, wow, no, I don't really want to come back. I'm not going to listen to what you're saying. So, we have to be present, smile, make eye contact, listen, observe, know the norms for the population that you're treating, if they're different than the general population, and listen with that third ear for anything that's unusual, that's outside of the ordinary, and start asking about it, open-ended questions. Be interested, show your understanding and demonstrate it. You don't have to like everyone, but you do have to get to this place where, that your patients are worthy of and deserving of your attention and your connection, and empathy and compassion. And when you show up like that, people start to change. They start, we are driven to attach, as much as any other, biological drive, psychobiological drive. We are driven to attach. And when you are connectable and people start to connect with you, they start to listen to you and they become motivated. And you start to see them starting to do things that you yourself are talking about. And that's how, change can start to happen. Okay, so you're doing that. Hopefully you're all really good at that. But I think, even if it's somewhat there is sort of even a kind of a performance aspect. Like, an actor, gets up on the play on Broadway, or a musician or whatever, they don't always want to perform every night, but, they can get into that space, putting everything aside for the moment, and just get into that space where they're present and doing it. And I think that's what we all need to do. So once you're there, there's how do we start prepping people, our pain management patients, to the point of really starting to hammer in on that CBT for pain. What are some fundamentals of prepping folks? And this is what we're going to do. We're going to talk about some of these fundamentals. Starting to differentiate acute from chronic pain, understanding internal and external locus of control, and some do's and don'ts, and like, how do you start to make some of these shifts for your patients? Now, what I'm going to say is, now you don't have to do this like lockstep. I'm kind of doing it lockstep. This is a naturalistic process. You're seeing people over time. You're kind of bringing them along. And so it's not like 1, 2, 3, 4, you have to like follow this, but kind of more or less you might want to follow this. And second, not everything here that I'm saying is actually academically, scientifically accurate. There is a lot of undoing that we have to do with our patients. Society has a very old understanding of what is pain and how to treat it. That's ultimately just wrong. It's 400 years old and it's wrong. And yet we are still sort of captivated by this model of pain, that all pain requires tissue pathology, and we have to focus on the tissue pathology. So we have to undo that. Even healthcare providers are really, some of them are bought into this older model and have talked their patients about it a lot. And so we have to kind of sometimes undo what our healthcare system has done for our patients too. So this is a step-by-step process. Admittedly, some of these things that I'm going to talk about is not scientifically accurate, but you're kind of moving people in the direction of a more scientifically accurate understanding of pain, step by step. And so maybe the very first, most simplest definition of acute and chronic pain is like, a duration, 3 months or less, or 3 months or longer. And that starts to begin a process of helping people understand, okay, the helpful heuristic that there's a difference between acute and chronic pain. Now, again, scientifically, there really isn't all that much of a difference. All pain is pain, all produced in the brain in response to what the peripheral nervous system is sending to the brain. But as a helpful heuristic, it's sometimes helpful to kind of start to differentiate them for the time being. We might also start laying down, some casual conversation around, acute pain is associated with an underlying injury or illness. Again, that's not actually typically accurate, but we're going to go with it because that's what they believe and that's what many healthcare providers believe. But it usually goes away after a little while, It usually helps 95% of the time whenever we hurt ourselves. It hurts for a while, but it heals up and it goes away, right? Whereas chronic pain is often something that lasts beyond that point of healing. Or society, or even some healthcare providers think of chronic pain as a result of a chronic injury or illness, but that's not always the case. You're just sort of like dropping this stuff. Trying to foster some curiosity in the patient to go, well, what do you mean? And then you can start to kind of move into it. Chronic pain is sometimes, this is one that I will use a lot, sometimes chronic pain is referred to as complicated pain because what initially caused the pain is not now the only thing that's maintaining it. Now that's a little bit more sophisticated, right? We're still acknowledging there may be some chronic injury that's unhealed. Probably isn't true, but we're going to acknowledge that for a moment. And yet we're introducing that there's increasing variables here at play. What chronic pain is when, there are multiple variables maintaining pain over and above the thing that initially caused it. And that helps to kind of get some people curious. And it could start to say from there, kind of talk about the vicious cycle. Pain, particularly chronic pain, has caused a lot of problems in your life. And you can insomnia, or you're out of work, or you're having financial stress, or your spouse doesn't believe you. And all of this stuff is stressful. And they're like, yeah, I know, it totally is. And that stress, we know, makes pain worse. And over time, you start to see this vicious cycle starting to happen. Pain causing stress, and stress exacerbating pain. The more pain you have, the more stress you have, the more stress you have, the more pain. And they're like, you're starting to kind of understand, okay, yep, there's more to this picture. We'd also then introduce some of the times when patients will come in, they'll say like, well, my surgeon can't explain why I have pain. They said they did their job and it looks fine. The fusion holds and they don't know why I have pain. And yet my pain is excruciating. Well, here's an opportunity. It's like, well, yeah, that sometimes happens. But if we have a more sophisticated understanding that, well, maybe your chronic pain is now being maintained by multiple factors over and above what initially started it. It's not the only thing that's at work here. And that we can start to explain why MRIs don't always explain all the pain. That there are multiple factors. We can kind of go back to that vicious cycle again. Or when patients will say, their provider or their surgeon said, you shouldn't have as much pain as you have based on your MRI, or your MRI looks normal. And they walk away thinking, hey, saying it's all in my head. Well, here's some opportunities to start creating a more sophisticated understanding of pain. That tissue pathology doesn't just equal pain. And wherever there's pain, there has to be tissue pathology. This is this old model of understanding pain. And we're trying to move into this area of like, there are other factors at work here beyond tissue pathology. Now, academically, we know that tissue pathology rarely correlates with pain, and in large-scale studies, never correlates with pain. We don't want to hit them over the head with that because that's like too radical of an idea, even though academically it's true. We have to sort of move them step by step through this process. Or we might say, gosh, from an evolutionary perspective, pain is our kind of way of telling us that something's wrong. I put my hand on the hot stove, and if I didn't have pain, I wouldn't know until I was actually smelling the burn. Pain is kind of a useful thing to have. And so it's telling us something's wrong. And so it's like this fire alarm system. Now, it's like a fire alarm system where, the fire alarm goes off and it's telling us there's something wrong in the building. Now, we don't hear pain like we do an auditory alarm system in the building, but we feel it. essentially saying the same, it's doing the same thing. And then we kind of say, now chronic pain is like this fire alarm system that's malfunctioning. It's going off, in response to stimuli that it shouldn't go off at. It's like somebody's smoking in the building and it's going off. Or we just can't turn off the alarm system, regardless of whether there's something going on in the building or not. So we're kind of moving them along around this, more and more sophisticated. Ultimately, we're going to break here and move on to a different topic, but ultimately where we're going is we're going to start to introduce the role of the nervous system in response to pain, that the nervous system produces pain in response to different stimuli, and switch them from a focus on the tissue pathology to the nervous system as a producer of pain. Before we get there, though, we gotta talk about another concept from psychology: external and internal locus of control. Ooh, I got 10 minutes. Internal and external locus of control. This is kind of the fancy way of saying, where does your power lie? To affect change in your life, whether it's a healthy change in terms of like your physical health or your mental health, or whether you're going to get a job or not, or have a family, or blah, blah, blah. Where does your power lie? Do you look to things outside of you to make things better or to make change happen, or do you look to something inside of you? And both has its pluses and minuses. We do live in a social world, so that does an external world that does affect us. So, but there's problems if we are overly reliant on the external or overly reliant on the internal. And I would put to you that our patients in pain management, the healthcare seeking pain patient, is typically somebody who's overly reliant on an external locus of control. No, very helpful fact to know is that the majority of people in the general population with moderate to severe chronic pain are not chronically using the healthcare system. They are working, they are managing and coping pretty well with life, and they are not taking opioids. The majority of people with moderate to severe chronic pain in the general population are not taking opioids and overly reliant on the healthcare system. Our patients, though, we see that subsample of folks who are higher levels of externalizing of control and are looking for that fix. Now, we have a healthcare system that's perfectly set up for that, because in an acute care model, we are the experts and we're going to fix people and make them better. So it's like this great match. But it ultimately, as we kind of suggested earlier, it's not working so well. So we have these folks, we'll see them, we all know them, and we can all have a lot of empathy and compassion for them too, because they're vulnerable and they're in pain and they're in distress and they're wanting a fix. They're oftentimes, are upset that these long list of discrete therapies haven't worked, and that they're in this passive dependent role of relying on the external system to do something for them, to get them better. So how do we start nudging them along in this process? Just thinking about, well, yeah, we're gonna end on these fundamentals, so we'll have enough time. So we're gonna start nudging our folks from a predominant external locus of control to a more internal locus of control. And so, there's some do's and don'ts here. Don't represent yourself as an expert provider who's going to patch them up and get them all ready to go. Don't buy hope by over-promising what you can do, because, gosh, remember, we're not very good at alleviating pain. And so don't oversell yourself. Don't set yourself up as the hero who's going to get them better. And notice when they start interacting with you like that, You want to sort of like lower those expectations about what you can and cannot provide. Even down to the sense of like, opioids are not medicines. The medicines make us healthier. They cure us. These are medications that manage things. Chronic. These are medications that manage a chronic condition. They're not going to make you better. Or time out when somebody says, what, are you going to take my pain management away? As if pain management is defined by opioid management. Notice the externalizing of control. Because remember, we are responsible for our own health. I am responsible for my health, not my healthcare provider. And we need to help folks sort of make that change. Adrian Lowe has this great distinction, words that harm and words that heal. Let's just call back pain back pain. Neck pain is neck pain. It's not spine pain. It's it's not because of your degenerative disc disease, your herniated discs, or don't buy validation by saying, oh my gosh, you have a spine of an 80-year-old. That's a good sales technique, but it's not an accurate thing to say, and it's not very helpful. I would also suggest getting rid of your spine and joint models. When you explain pain, let's talk about the nervous system, the system that's actually responsible for your pain, because one can have all sorts of arthritic joints and spines and have no pain. And one can have pain with, a pristine joint. So let's get rid of those. They teach us to become that. They teach us to think of chronic pain as a chronic injury that just remains unhealed, and that's not true. And it creates guarding and fear avoidance and bed rest and couch rest and all that sort of stuff. All those things that we don't want folks to do. So this is a kind of a big thing. Instead, let's start using analogies to other health conditions, particularly, hopefully, ones that the patient doesn't have, but they have some knowledge of, because you're trying to like circumvent their defensive reactions. Heart disease. What if you had a friend who just had a heart attack, and your friend, you love him and everything, but he's quite overweight and he smokes and he's always stressed all the time, and he lives on frozen pizza and Culver's, and he says, my bypass surgery, it didn't work. I still have heart disease. Or my doc says I'm still at risk for a second heart attack, even though they gave me that bypass surgery. What are you going to say? How might you say, what, there's more to heart disease. Biology really is about lifestyle. And, maybe you have a role of ways of getting better, right? That's what kind of you would say, right? And most patients would say, yeah, I get that. Yeah, probably does have to stop smoking, and that would reduce his risk for a second heart attack. And he probably could start exercising, losing some weight. And then you kind of say, gosh, what? Pain is a lot like that. There are biological reasons for your pain, but it's also about things that you do, that you can do over time that can affect your pain. And particularly when it comes to chronic pain. Now, this is also true of acute pain too, but let's just stay with chronic pain. And then, you might want to use, in the interest of time, let's keep going. So there's various analogies that you can use, and as well as contrasting analogies. Like the strep throat example. You can get better. There's no doubt you can get better. It's going to take some time, but you can get better. You're not going to get better like, taking an antibiotic for a bacterial infection. You're going to take it 3, 4, 5 days, 7 days, and you're all better. That's not how you're going to get better, though. Getting better is going to be in a different way. Can we talk about that? Sort of use contrasting analogies. Might also, I like to use, this is kind of funny, but I happen to know a little bit about ancient Greece for whatever reasons. But, you think I'll sort of introduce like, the ancient Greeks, like you ever heard people like, Aristotle, Plato, those kind of guys, those old white guys. They had this kind of notion that got translated to moral luck. And I use that example because everybody's going to know what I'm talking about once I start talking about it, but it's a way to sort of circumvent their defensiveness because I'm introducing it in a way that I know almost for a fact that they don't understand this because they haven't studied ancient Greece. And so, this translated into moral luck, it's sort of like, this old saying, when bad things happen to good people, life happens, bad things do happen. And, we're going to be here with you and for you. And yet at the same time, it is now yours and you have to start taking responsibility for it. And the people, you can stay mad, you can stay in this sort of injustice mode, chip on your shoulder mode. It was that surgeon who did it to me, or that guy who hit me in the car with the car. You can stay mad, or, but the people who can actually start getting better are the ones who start saying, however unfair it is, they start taking responsibility for it and start managing it, start living in different ways, and they start to do better. And I believe you can do that. And that's a tough conversation that oftentimes creates a lot of tears, but it's a very important conversation to kind of start moving from that external to the internal locus of control. I talk a fair amount of, the limits of procedural care, and I do it pretty matter-of-factly, and then I talk a lot about how, like, not all pain clinics are alike. There are lots of different types of pain clinic. Low back pain is one of the most common health complaints in the healthcare system, and yet we don't agree how to treat it. There are surgeons, there are interventional folks who do injections, there are chiropractors, there are people who give you opioids, there are people who do rehab, there are people like myself, and we're all treating the same exact condition very, very differently. And you've tried all that. You've tried all those fixes. They're so-called fixes, and maybe it's time to try it a different way, focusing on what you can do to best manage that pain over time. Let's not keep sending you back to the surgeon. They've already told you it's not going to help, or you've had umpteen steroid injections. You can continue to do that, but you just told me it's not very helpful. What if we start working on what you can do to manage this? And so here's a quick slide. I have this on a sheet of paper, where, we start differentiating. There are two types of healthcare. There's actually three if we want to the palliative care model, but, there's two types, and they all both have their time and place. If I have an appendicitis and I burst over with abrupt abdominal pain, sweating and fever, blah, 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 I'm going to have an appendectomy. And I'm going to rely on the expertise of that surgical team. And I'm just going to be this sort of passive recipient of it. But, if I have a chronic disease like diabetes or heart disease or pain, even certain types of cancer, I want to kind of know what I can do to best manage this over time. And when, lifestyle is biology, I'll say that over and over again, lifestyle is biology. By changing your lifestyle, you have an effect on your physiological body, and they're like, well, what do you mean? And I'm like, well, have you ever dieted? You changed your attitudes about food, you changed how much you're going to eat, you changed what you eat, you started to exercise, you started to manage your stress, all this lifestyle stuff, and you lost weight. That's changing your physiology, right? Well, let's do that for your nervous system. Let's change your nervous system. But I can't do that for you. Here's again, we're kind of moving that. We're going to give this ball to them. I'll coach you how to do this. And in fact, this is called the rehabilitation model of care. Coaching folks on how to, what to do repetitively over time, and they start to change their physiology. And it is the most effective thing to do when you have a chronic pain condition. And, the hope lies in you taking back control over this. It's not like trying to, go to the ends of God's green earth, trying to find an expert to fix you. It's like, let's teach you how to have this power to get better. And, there's the more you do, the better you get. We all know the more surgeries you have, the likelihood of getting worse is going up and up and up. Or, the more procedural care, the more meds you take, there's a point of diminishing returns. Whereas with rehab, the more you do, the better you get. And so kind of move that, folks, along. Last slide. Oh, sorry. Why don't I wrap up? We want to do that case. I thought it was at 1 o'clock. Kurt, Heather, what do you think?
Yeah.
Yep.
Okay, so why don't I'll wrap up.
Okay.
So
you could just
last
make
thing.
it come back, Murray, and finish another time.
Well, it's okay. Just last thing, when they start to actually make some behavioral changes, get all over it, reward the heck out of that, but not like in a facile way, like, good job, good job, buddy. They're adults, right? You don't want to talk to them like a 3-year-old. But you do want to like stop the show. Okay, let's, reward it with attention and questions and interest. It's like, whoa, wait, what did you just say? Let's stop that. Let's time out here. Let's talk about that. What you said you just did. Now that's you doing it. You brought that about. You didn't just get lucky. The stars aligned, right? And you had less pain. You actually said, by going to the gym, I started to feel better. It's like, that's you bringing it about. You and your own internal ability to affect change. And you're like all over it. And people are like, yeah, okay. So that's kind of, now from there, we would move into sort of like what we talked about last time, which is how do we deliver that more nuanced CBT for pain, where you make that shift to, let's start talking about the role of the nervous system and how to neuroplastically change that nervous system in order to you having less and less and less pain over time. So why don't we wrap up there?
Perfect.
Hopefully there's enough time.
One big question about how do you recommend getting the world to get with this and get policy changes or get insurance? You know what I'm saying? I mean, I know you worked on this and all of that. It's just, is that just waiting for the stars to align?
Well, I mean, we've all been working on it, right? I mean, look at what look what you and your team have been doing. I mean, you've had a pretty profound impact on how to treat opiate use disorder.
Yeah, baby steps, right?
Yeah, until Chris is talking, and then you can see our profound knowledge.
All right, well, let's get to the case. But Murray, thanks again. That every time you speak, it's so interesting and kind of out of the box thinking and kind of making us think differently about what we do every day. So really, thank you so much.
I think you're the only person whose thought processes, like Kurt, really
it almost mixes me up.
Catch up. It's not there.
All right, and I don't know if you want to hang around. This is kind of actually an interesting case. We'll let Christy kind of take over.
Hi, my name is Christy. I'm a nurse care coordinator for our program at Wellia Health in Mora and Pine City and Hinckley. So this patient, sorry, I'm just getting her chart up here. She's a 23-year-old female. She's been in our Suboxone program for a couple months now, I believe. She has a history of anxiety, depression, bipolar, ADHD, was using opioids, alcohol, marijuana, meth before going into inpatient treatment. She ended up with us because she's been in a local inpatient treatment facility. She actually came to us while she was still there. Just trying to scroll back to that. And she was on Suboxone when she came to us. She's not on a lot of other medications. She's on Seroquel, actually new since I wrote this case. She's on the birth control pill, and then she has Narcan as needed. No concerns as far as PMP. Her drug screen results, she's had 2 positive urine screens since starting with us for oxycodone specifically. The first one, she just adamantly denied any kind of use. And we did send it off for confirmation, and it did come back negative. And that second one, the doctor, it was the same thing. So he didn't even send that one for confirmation. He said, we'll send it if it comes back again. But so other than that, no other concerns as far as her urine drug screens. She has 4 children, 3 in foster care, 1 in her custody. But CPS is heavily involved. The children's dad, they are very supportive of each other. They're not in a relationship, but they are supportive. Again, she's got open CPS case and probation through Candy, Ojai County. She's gone through treatment 4 times in the past. Currently, she's still doing outpatient treatment. She's now graduated from inpatient treatment. She's living in sober housing. She comes into our facility 3 days a week for urine screens for CPS. And when she first came to us, so early May, it looks like, she had been in treatment for about 90 days. She was close to graduating. They initiated her on Suboxone. Their provider does not go over 16 milligrams a day for prescribing, and she was struggling with that dose. We increased her at that first appointment up to 20 milligrams. And after that is when she kind of graduated, moved into sober housing, started outpatient. I think that was all within the same week. We saw her a week later. She's still just struggling, always thinking about drug use, struggling with cravings, very worried about her sobriety, though she had not relapsed that we know of, just constant consumption of thoughts of using. Our provider increased her to 24 milligrams at that point. She came in a week later, still struggling. At that time, she was taking her medication just all at once in the morning. That's how she was doing it in treatment, and she just didn't have a problem with it, so we didn't change that. But our provider did recommend, okay, let's try splitting it up, see if that helps with any of your cravings. That did not help. May 31st, our provider, we've only done this 2 or 3 times, I think, since we started almost 4 years ago. He tried to prescribe her 32 milligrams a day with the hopes that that would be a temporary thing that wouldn't last long, but hopefully it would help just in this new sobriety period. But her insurance denied that. They denied our PA. They denied the appeal that we tried to write for it. So she started that dose, but was not able to continue it for long. So at that point, our provider actually referred her to a methadone program, which is not something we've ever actually tried to do in the almost 4 years that we've been doing this. We've never had a situation this intense where someone just really felt they were struggling every day. She was using, and I know it doesn't always correlate, how much Suboxone someone takes with how much they were using, but of note, she was using a huge amount of those Perk 30 tablets, reportedly anyway. And her use seemed to escalate from like 0, like she wasn't using opioids. She'd used meth for a long time, but wasn't using opioids other than some, here and there. Until within the last year, I think it was a brother that introduced her to these Perk 30s, and her use went from 0 to like high, just super quickly. The point, my main question here at this point is we're struggling a little bit with this referral. So the closest methadone clinic to us is about an hour away. It's in St. Cloud. They are not accepting new patients at this time. The second closest is in Brooklyn Park. I have tried to contact them. I've left several messages. I'm not getting any return phone calls. Even if I can get her into a clinic, she does not have a vehicle or a license, I believe. So we would have to make sure medical rides were a thing, which I know can be a little tricky, especially if you're trying to set them up every single day. So I'm mostly wondering, and at this point, this has been a few visits now that we've seen her since all this came up. And with the struggling to find a clinic for her, between that and just, she got really worried about that false oxycodone result because of CPS, that she was just like, you know what, I think I just am at a place where I don't even really necessarily want to switch to methadone. I need to just accept that I'm going to still have cravings and just kind of work through it the best I can. She has not relapsed that she's reported or that we know of. So I think she's at a place now where she's just going to continue Suboxone, but I am looking for any input as far as her treatment. I know I've talked to a couple of providers. I think Dr. Bell maybe recommended, is she having meth cravings? Could we help with that? Is that some of what's going on? So I'm looking for any suggestions as far as her treatment. And then also if anyone knows of a methadone clinic that is like a good, I don't love referring people places that I don't know anyway. And I could refer to HCMC. I talked to Dr. Reznikoff yesterday. It's a little further. So I don't know if medical would even transport her since she does have closer options. But I'm looking for if anyone knows of a good clinic that's actually taking new patients or that works with you, and then just any other thoughts on this patient.
Yeah, why don't we start with a couple of questions? Because my first question would be, what mental health meds is she on? I'm just interested if she's on.
Seroquel.
That's the only one.
I'm double checking, but I'm pretty sure. Yes, just Seroquel.
Yeah. And my other, go ahead.
What other support is she getting, Christy? Like, does she have?
So she's been working with the same counselor, like therapy, for over 2 years, well before she came to us. I believe they're from Nystrom and Associates, back from like where she lived. So she's doing video visits. She's still doing outpatient 3 days a week. CPS has visited her at least a few times since I've been working with her. So I think she has she's clued into kind of everything like that I would send her to.
How about like socially, like family or close friend or?
Yeah, I don't think she has a lot other than that baby's father. And I don't think she's close, like proximity wise, I don't think she's close to any of them right now because she's living in sober housing here and her people are from Candy, Ohio County.
Yeah. You know, one of the things, Christy, too, I just had a patient yesterday that couldn't get into St. Cloud as well and ended up in our building. And I think Charlie actually talked about that, how the problem is they don't have enough LADCs, so they can only take so many patients, and that's statewide.
Right.
So that's going to be a real big issue. So.
Well, now I think the one question, and I think Murray's talk today was timely when it comes to and Murray's reactions when you were talking were great because, you know, timely and is this more the mental health concerns? Is this more the anxiety? And this is her coping in a way. It was interesting to hear you say that she had made that comment of, I'm going to learn to have to kind of, honestly, deal with the cravings on her own, but, you know, learn how to manage with them there. So I would like Murray's thoughts, unless he just typed them all in, because I don't know who just typed that message. Yeah, Murray did.
No.
So,
I was speaking to Annika.
Okay.
Well, what I was thinking, and I don't know who might do this within the Minnesota area, but like I was thinking of Eric Garland's work that, you know, we heard him, I think it was, you know, where they're doing targeted retraining of how to retrain the response to an urge. You know, like how do I have an urge and start, you know, retraining my response to the urge, so that I can tolerate it, increasingly tolerate it. That was kind of like the basic thing that he was doing. And that's kind of what we do in pain management. It's like we're changing the response to pain and kind of neuroplastically doing that over and over and over again. And I wonder if there's somebody within Minnesota who's doing that with like relapse prevention, like how to have an urge to use and practice changing your response to it.
Yeah.
Well, and I think like when I've had this where patients will say they're having cravings, and if it's only every once in a while, it's like, okay, but what did you do in that moment rather than use when you had it? And then try to like talk through that, unless it's like a constant craving, then, that's a little bit different.
Yeah.
What did Charlie tell you, Christy, besides, yeah, I guess she can come down here?
I'm curious if I would have talked to him a couple weeks ago versus yesterday, because like I said, I feel like we kind of have gotten to this point now where when I first brought this up, it was a lot, the patient was struggling a lot more. He kind of said the same thing, it's a bummer that you couldn't try the 32 milligrams, but since you can't, he had a really good quote for me, and I have it written down at my desk, but I'm over in Hinkley. It was like, perfection is the enemy of good or something, just reinforcing that she's, you are struggling, yes, but you haven't relapsed and you are overall still doing well, and just kind of like trying to support her through this the best we can. And I was hoping like maybe he had some other methadone clinic contacts, but he said that's not really his, he's not Mr. Community or something like that is how he worded it. So I was more so like, if this comes up in the future, I'm looking for if anyone has clinics that, like I said, St. Cloud was great. I get it. They can't take new patients. But it's like, I can't even get a hold of people. So I'm looking for like, if anyone has any good places that we maybe would refer to in the future.
And I think that's, if again, the podcast we released yesterday on the methadone clinics, and then over the next couple of weeks, I think the one in 2 weeks where we talk about that transition from methadone to Suboxone, and should you do it for this reason, like Kurt just mentioned, is the limitation is the LADCs, and that's why they can't take new patients, like federally mandated can't. So what do we do about that in the world, especially when you're out in the middle of nowhere? And really, Charlie's on that, and he's like, I don't know, like it's doing what you can and empowering that patient to, help them through that moment.
And I think, if I was faced with the same situation when she was really bad, I would have been leaning towards a methadone clinic as well, which I've only done one other time. But when they're craving that badly, you're just to get them. If they relapse, of course, then we're all bets are off. Now it's like, well, how do we look to kind of curb these? And I think somebody put in the chat about maybe switching her Seroquel to something like Remuron, which some of us have used for meth and occasionally opioids. We've talked about topiramate, and the other thing is time going to just be enough. Is it anxiety, or is it is there other things? Is it a mental health eval? Would that be worthwhile? And so yeah.
I don't know. Beth, I do have a question for you though, because of the question is there, like, how common is a rapid metabolizer, or is that even a thing? And does that even happen with, like the buprenorphine? Because I know there was that question, Christy, when we first talked is it just that her body's breaking it down too fast? So I don't know, Beth's not there, her name is, but that might not
she
be
might have walked away.
Well, and one thing Dr. Resnikoff did say about that was that he suggested I do some research, so I plan to when I can, but apparently if you do rapid metabolize certain opiates, it doesn't mean it will be that way with all of them. Like, each is individual. So he told me to kind of look into that a little more too.
Yeah.
I do like what Laura mentioned is, having her therapist or her counselor or whatever, maybe getting an additional therapist or counselor, maybe even a peer recovery or an LADC in the community to work through, that emotional aspect of craving, because there is that physiological response a lot of times with the craving and working through that. So then it gets less and less
Well, I think with a lot of chronic patients, we do a very similar thing where instead of having them come in when there's trouble, we have them just come in every Monday, right? So that it shows that you care. It shows that, you want to be involved, that you're thinking about things all the time. And this is probably somebody I would be seeing frequently, if nothing else, I think, to support them. But I like the mental health thing as well, a weekly mental health thing, if that's possible. We all know how tough that can be. So I don't know, anybody else with any thoughts?
I really like the idea of like really focusing on the relationship and garnering solace and support from that. I also wonder, like, and maybe she has, and maybe I might have missed this part, sorry, because I was responding to the chat, but has she been adequately prepared for how hard this is? To kind of validate that, this is hard. This is really hard to do. And, no matter how great of a medication that Suboxone is, it is only so good. And you're going to still have to do some hard work here. Yep. Maybe having that kind of conversation too. I don't know.
All right. Well, I wish we had a perfect answer for you. Like there's a methadone opening today.
All right. But I don't, would that even help? I mean,
yeah, we don't know. So maybe you let us know how this goes over the next couple of weeks, Christy. I think we'd all be interested in just whether this finally slowly resolves and gets better and better, which is, I think, what we're all hoping with support. So, all right. Well, thanks so much for presenting that.
Yeah, thank you guys.